Welcome everybody to the Med Crash Course final series. Today we're covering infectious diseases part 2. Please check out part 1 over on YouTube, as all of the courses are uploaded onto YouTube, and today is being taught by Dr. Crawford, who I believe is a George's graduate.
Yes, indeed.
So maybe a familiar face for some people joining. As with all of our final series, please do check your university notes and guidelines, because these are the guidelines that the doctors are using. However, we know that universities can be very specific about their guidelines, so just make sure to check that and not solely rely on this as your source of information. There will be a poll available to do throughout the talk, and there's also a feedback link which I'll be sending around, where you can get access to the slides as well. And without further ado, I will hand over to Dr. Crawford.
Great, thank you very much. Thank you very much, Mika. Good evening, everyone. Yes, my name is Adrian Crawford, and rightly so, I'm a George's alumni. Currently working in Basingstoke Hospital, finishing up my foundation training. Currently rotating in ED. Great, so let's get started. Part 2 will mainly focus on virology and a little bit, like one slide on fungal infections. It's a very sort of clinical based lecture, so we're not going to do any sort of real detailed sort of physiology or description of viruses and sizes and capsid regions and stuff like that. Now we're just going to look at all the clinical presentations of some of the viral infections that are mainly that will mainly sort of pop up in exams. If you do have any questions, either just raise your hand, either I'll see them or Mika will see them, or just literally butt in and ask, and of course take part in the polling. And we'll get started. So I think the link to the poll, if you just scan sort of with a QR code, then that will give you some sort of sorry about that. That will give you access to Vvox, and Mika will be manning that. All right, cool. So should we get started? All right, let's go. So I'll give you some time to try and log into the polling, and we'll go through it with some questions, and that way we can basically, well, this is how we'll basically do the course. All right. Let me know if you do have people logging into the, maybe I'll go back. If you do have individuals logging into the polling, Mika.
Will do, and I'm also posting the link in the chat as well.
Okay, cool.
Okay, I think that might be everyone so far.
Yeah,
If you can go back to the question.
Cool. All right, let's go for it. So I'll give an opportunity to read the questions and then answer it. Mika will deal with the timing, I guess.
Okay, so we'll give everyone about a minute, maybe 2, just to read through and think of an answer. Okay, so I believe everyone has answered, and we've got the majority going for C.
Yeah, okay. Go for C. Great. And that is the answer that I would go for as well. So it's a 45-year-old lady who's obviously got an oxygen requirement. and she's got a high rest rate, so she definitely needs oxygen. The fact that she needs oxygen means she would need to be admitted, because I mean she won't have oxygen at home. And we'll give her some IV paracetamol. You can give her orals as well, but so just some paracetamols just to keep her temperature down. We'll do some viral PCRs because of her X-rays, which show some ground glass opacity, and we'll refer to the inpatient team. Now, this is sort of pointing towards a viral infection such as, you know, influenza A, influenza B, parainfluenza. It's quite common, particularly over the winter. And if anyone sort of goes into ED at some point during their training, they'll come across it quite a lot. And it's kind of this non-specific sort of presentation, actually, or prodrome, as some books will call it: fever, dry cough, sore throat. Basically sort of coryzal symptoms, as some books describe it: runny nose, a bit snotty. Now, we won't bother with the incubation period, but the main thing to note is that it's generally no treatment really if the patient is stable. And only in high-risk patients will you give Tamiflu. You'll see it, sort of the proper name is oseltamivir. It's basically an antiviral. So you'll give them Tamiflu 75 milligrams twice a day for 5 days. Some trust will also have guidelines where anyone who's been in contact with this individual should also get Tamiflu, but that's only in high-risk individuals. So people with like lots of comorbidities. So, for example, you know, lots of cardiac conditions, respiratory conditions, diabetic, etc., or people who are sort of going through chemo or any sort of immunosuppressing treatment, or immunosuppressed, etc. Okay. So that's it for influenzas. The main point to take home is high-risk patients, antivirals, ground glass opacities on the chest X-ray really points towards a viral infection. And I think, I'm not sure if there's anything else from the question that would stand out as to why. I mean, she's got white blood cells within the normal limit. Oh, insignificant PCT. So this is actually a key thing here, and I think if I see if this pen works, insignificant PCT. Now, this procalcitonin basically helps us to differentiate whether someone's got a viral or a bacterial infection, and the fact that the PCT is negative points to the fact that, you know, she's more likely to have some sort of viral infection. All right, and we'll come over that again. Okay, let's go over question 2. Whenever you're ready, just start with the questioning.
Okay, we have the vast majority going for A.
Majority going for A, and that is correct. So we've now gone into the realms of hepatitis, and it can be quite tricky actually going over this. So we'll go over as to why the indication is A. Okay, so hepatitis B serology. If we go for hepatitis B, it's probably the most common one that you'll be tested on. Now, I think this is something, if someone's got hepatitis, it's people always get this one. Sometimes in OSCEs, they might get it missed. Just remember that there are other causes of hepatitis apart from viral infections, okay? And that's always a tricky one when you get to OSCEs. You know, there's also alcohol-related cause of hepatitis. But on the written exams, they always seem to want to go for the viral causes of hepatitis. and they always seem to want to give you these surface antigens or these antibodies. Okay, now if someone's got a hepatitis B surface antigen positive, okay, and so according to question, which indicates an active Hep B infection, then it's going to be the surface antigen. If they're surface antigen positive, then you know that they've got an infection. Okay. Now, of course, they're also going to be Hep B core antibody positive, and the way to differentiate whether this is a past or a current infection is to use IgM. Okay, IgM or IgG. So if it's IgG, obviously they've had this infection in the past. If it's IgM, then they are basically, it's an acute phase, and then you basically need to pretty much sort of learn and memorize this list. If they're hepatitis B surface antibody positive, they've obviously either have an infection or they've been vaccinated. Okay, so those are the key ones to remember. The Hep B surface antigen, if that's positive, it means they've obviously got the virus in them. If they've produced antibodies, we don't know if this is because they were vaccinated to have these antibodies in the past or whether they're infected recently, but we can use the IgM and the IgG to tell us whether it's a current or past infection. Now, the antigen to the Hep B, so the E antigen and E antibodies, is basically used to help us to know basically how infective they are. The key one is the antigen. So if that is positive, then that person is highly infectious. And for anybody who goes into virology or microbiology or infectious disease in the future, this will help you to guide how you manage your patients on the wards or in the community in terms of their infectivity. Okay, and so I've noted at the bottom, when screening for Hep B, test the core antibody and the surface antigen, and if that's positive, then you go for the E antigen because it helps you know how infective they are, and the viral load if you want to. All right, great. Let's go for question 3.
Okay, we have the majority going for C.
Okay, great, excellent. And C is a correct answer. I hope these questions make sense. I wrote them sort of randomly after my night shifts, so hopefully they're all making clear sense, which by the answers they seem to be anyway. So yeah, so 75-year-old gentleman. So we know he's a smoker. Okay. I threw that in there because that could change things a bit. We know he's got COPD. Okay, with regular exacerbations. He's currently got a sudden onset shortness of breath and an oxygen requirement. Okay, so if you're on the wards, particularly if you're in ED, you'll be making lots of referrals. I mean, you don't have oxygen at home, so you're going to be admitted. Okay, regardless of what the bloods show, etc. So we know he's got a high CRP. He's got a high white cell count, but his procalcitonin is negative, and he's got ground glass opacity. Okay, so this, as to our first question, points us towards some sort of viral infection. All right, so COPD exacerbation, It's unlikely. Yeah, sometimes you can get some coexisting infections, but it's unlikely based on the numbers shown up in the blood in terms of the procalcitonin, etc. Community-acquired pneumonia, that's always a reasonable differential to have when you're clerking someone before these results come up. But coronavirus is obviously going to be the more likely diagnosis. So this guy would obviously need a PCR, which is pretty much routine now in all sort of initial workup for anyone that comes in with shortness of breath. Heart failure is a possibility, very unlikely. So these are all very good differentials, but heart failure is less likely. COPD exacerbation and CAP, you know, you could say moderate, but COVID is based on the results as the most likely diagnosis. Okay, now the key points to take is that obviously on chest X-ray, ground glass sort of picture, which you get in the lower bases usually when someone has a viral infection, and over days it can go on to a more consolidated picture over the whole lung field. The procalcitonin is your friend when you're trying to decide whether someone might have a bacterial or viral infection. And you sometimes find that the lymphocyte count is quite low on most of your patients with viral infections, respiratory viral infections. So those are two key things to help you in making a decision. If you see someone like this, you can test them for COVID, you can test them for influenza A and B, and one of those results will come up. Okay. Now the treatment guidelines are always changing, so basically look at your local policy. But the main thing to remember is if they've got a oxygen requirement, they're likely or should have in your trust, well, in my trust anyway, you'll give them a steroid. Okay. And we currently give them dexamethasone 6 milligrams up to 10 days or as soon as they're off oxygen. And if your trust guideline or your university guidelines, or whichever guidelines they follow, whether it's NICE or whatever, you also go for remdesivir, and that's usually for about 3 days. Okay, and it's usually IV. But the key thing is oxygen requirement. Definitely want to give them a steroid. Okay, dexamethasone 6 milligrams, and then you can work up remdesivir or some other one of the MABs at some later point. Like I said, these are all very clinical questions, a very clinical presentation, and it should help. Question 4.
Okay, we have a 50-50 split between B and C.
Between B and C.
Yeah.
Okay, cool. So I wonder, must be the way I wrote this question. So I guess maybe in a real exam they'd probably chuck it out, probably throw it away. So the answer I was looking for was A, really, and let's talk about my reasoning behind this, and we'll look into it. So we've got this 35-year-old gentleman And unfortunately, in medicine, when they write their questions, it's very stereotypical. So whether it's TB, whether it's infectious diseases, whether it's cystic fibrosis, they always find these stereotypical people groups or stereotypical attitudes or etc. to come up with their answers. So this is a guy who we know has got sort of sore throat, diarrhea, and that's probably the key thing. The runny nose could throw you off a bit. We know that he travels a lot. He travels a lot to Singapore and to Thailand. And he's recently noted a lump in his neck that's hard, fixed behind the ear, tender to touch. And I can see why, now looking at this, why he probably got pushed towards lymphoma, leukemia. This lump in the neck, hard, fixed behind the ear, tender to touch, is probably what's thrown most of you, if not all of you, off, and probably I could have taken that out. But the question here is pointing towards maybe his sort of daily sort of attitude to life or activity while he's traveling abroad, and pointing more towards a sort of more frivolous kind of way of living, and probably a little bit less conservative in his sexual attitudes. Now, the GP has taken some bloods, and the main thing is that the bloods were unremarkable. Okay, so the fact that the bloods were unremarkable would mean that his full blood count, so the FBCs, are obviously normal, which would help us to then say, okay, you know, there's probably not a sort of leukemic picture, because I'd expect the FBC to look a bit dodgy. Okay, now it could be a tropical sprue because of the fact that he's got diarrhea. He travelled to tropical regions quite often, but his fecal fat assay is also normal. And there are other tests that you can use, obviously, for tropical sprue. So that would take this one out. The thing with HIV is oftentimes people usually present first with diarrhea, and they don't oftentimes present just feeling sort of with lots of infections or losing weight straight away. And you know, you're not just going to do a CD4 count on every individual that comes to the office or things like that. They usually just present sore throat, which obviously is one of the ways of signs of maybe, you know, being a little bit immunosuppressed, but not always. But the diarrhea symptoms, the fact that he travels a lot, he's quite young, goes to Singapore and Thailand quite often. His bloods were unremarkable in terms of the full blood count. And so we start to think, and this is why I put the word suspicion, because we probably can't diagnose straight away that he's got HIV, but this would be the high suspicion. I guess this question probably could have been worded slightly different. If anyone does have any questions or anything they'd like to clarify or to say, then do raise that point either now or at the end, and we can discuss it. But I hope that makes sense. But in an exam situation, this question probably would have been checked out, because obviously there was some misunderstanding, or maybe now it's become clearer to those of you who are hearing my explanation for this question. Let's quickly talk about this, and if anyone has any questions about this, then do let me know.
Yeah, I just have one question in the chat quickly.
Yeah.
Is procalcitonin useful as a marker for other infections, i.e. like non-respiratory infections?
Oh yes, that's a very, very good question. So procalcitonin is basically your friend when you're very junior, like myself. Lots of the time consultants will just tell you this person is just like bacterial or viral, and the key there is they use a lot of the neutrophils. If someone's neutrophilic, then they usually say, yeah, it's going to be more likely bacterial. So procalcitonin in any infection, if you get procalcitonin and it's positive, you're looking for a source of why this person's got a bacterial infection. Okay, so if they come in and their chest X-ray is clear, they've got no oxygen requirement, there's no sort of respiratory source for their infection, and you think, well, the procalcitonin is positive, maybe they come in, they've got a fever, then you probably think, you know what, this is probably like sepsis of unknown origin, or an infection of an unknown origin, or pyrexia of unknown origin, and you start to look for a source. You know, could it be bowel? Could it be urine? You know, have they got some open wounds? You know, have they got sort of like cellulitis? So if the procalcitonin is positive, it can be used for any sort of investigation of infections, not just respiratory. Yeah, that's a very, very good question. I hope that helps other people who were wondering that. Cool, thanks. Okay, so HIV. I try not to go over sort of these the anatomy of the virus itself, because usually I find them to be a little bit confusing, and these are the facts that you just need to learn before the exam. But clinically, we know that the main sort of detriment to individuals is the fact that their CD4 helper cells are destroyed. So basically the T cells are destroyed. Now, the key thing that you must remember for HIV is monitoring. Okay, that's the key thing. Treatment, I wouldn't really worry about too much. All you need to know is that there are lots of guidelines out there on what you ought to use. But the monitoring is what I think you'll be expected to pick up on. That will raise your suspicion of how unwell someone might be. So a CD4 count of less than 200 means that your patient is a high risk for opportunistic infections. And this is usually done obviously by the infectious diseases team or whoever's looking after the patient, but it could come up in the exam. Okay, that this patient, they've come in, they're feeling unwell, and it will just tell you they've been diagnosed with HIV, and the blood test shows XYZ, CD4 count is like 50 cells per millimeter cube. How would you manage this patient? They're a high risk of opportunity being infected by other fungal diseases, viral diseases, etc. And you want to give them something like broad spectrum or cold trim as a prophylaxis. Okay. So in terms of the viral load, they might ask you some questions around the fact that, you know, viral load is undetectable. Can this lady like safely breastfeed? And in cases, once the viral load is undetectable, then that's ideal. Okay, according to research, which is now accepted, transmission is unlikely through sexual activity, through breastfeeding, and vaginal birth can be considered. Some trust might still go along as just going through a cesarean section, etc. All right. Obviously, just know about PrEP and PEP, and all the sort of heart sort of guidelines and treatments. All right. Great. Let's move on to this question.
Perfect. We have a very quick response of everybody going for A.
Okay, great. Excellent. Sorry, I haven't got any pictures. I should probably put some pictures in my slide. But this is a very tired Adrian post night. So just completed my last night. So I'm happy that the questions seem to be making sense. And that is definitely A. And I've clearly asked, just on clinical review, and you don't need a test really. It's the fact that she's got this dermatomal rash, not crossing the midline. That's the key thing. Shingles. Now, it's caused by the Varicella zoster virus, or shortening VZ. And obviously, we know that that causes chickenpox, and later on in life causes shingles. And it's just a matter of knowing that, basically. It's just a fact. So chickenpox, obviously, pediatrics, okay. You get these macular sort of vesicles, and, you know, child will just have like fever, headache, non-specific kind of just lethargy, fever, headache, some pains. And they're obviously quite infectious, as everybody would know, up until the lesions sort of scab over, all right? So while the vesicles are there and are present, they are infected. And later on in life, obviously, as because the disease or the virus stays dormant, can come up with this painful sort of you know, region, as we said, in the dermatome, and that's why I've gone for this age, 69, and that's quite key, because at 70, individuals are usually invited for a vaccine to prevent shingles. And that's the only time you're really given a vaccine against VZ. We don't really vaccinate in childhood in this country. But for those of you who might have been born sort of in the US or that part of the world, you probably would have had a vaccine. Like myself, I was vaccinated against chickenpox, so I've never actually had it. But for those of you who are sort of born and bred sort of in the UK, then it's not routine. So basically you're just going to diagnose this clinically. You don't really need to do any tests. But if your patient's immunosuppressed or you just want to confirm it, then by all means, you know, you'll go for a PCR. And honestly, there's really no need to treat, but you can with some antivirals. And if they are pregnant or immunosuppressed, definitely treat them, and definitely try and give them some IV if you're worried. All right, great. Question 6.
Okay, so we've got the majority going for B with some votes for C.
Okay, cool, great. So the answer for this one is B. And we'll talk through it. Now, C isn't totally incorrect, because yeah, we would probably do CT head with someone who's had a bit of a bizarre behavior, seizure and collapse. But the initial treatment that will come after the initial treatment, and what we're pointed to here is some key things which always come up in exams, which makes you think about some kind of meningitis, encephalitis kind of picture. All right. Now, we know he's got some bizarre behavior. He's had a seizure. I can underline bizarre behavior as well. And he's a university student. They always seem to use, not always like 100%, but that's almost always a big clue that I found anyway when I was doing sort of exam practice, etc. University, and he's got a high temperature. He's had a seizure. The first thing you're going to do is obviously give him some antipyretics, and then you should have a high suspicion that this person might have some meningitis, encephalitis picture. So we're going to give him some IV antivirals and IV antibiotics. And that's just a standard protocol, even though you're not sure whether, because you're not sure whether this is viral or bacterial until you do all the proper investigations and all the workups. You cover them for both. After you've given them this, and it will be on literally, this is what it'll say on microguide. Give them IV acyclovir, IV antibiotics. It will even say IV dexamethasone, I think, as well. Definitely steroid on microguide. After you've done all that, you can send them for CT head. Then you'll do like, you know, a TAP, a CSF, etc. And this person's going to be admitted. All right. So the reason I came up with that question is for sort of encephalitis. It's one that can be caused by HSV, EBV, CMV, VZ, and I just wrote this question for HSV basically. So herpes simplex virus 1 and 2, and I think the anatomy is quite important here to help you to decide. So I usually say anything above the waist is HSV 1, okay, that's how it's taught, and anything from the waist or including genital region is going to be 2. All right, so someone's come in with some sort of lesion on the lip, and they've obviously got a HSV infection, it's going to be HSV 1. If they got a genital lesion, it's going to be HSV 2. Yeah, and you'll know that based on sort of diagnosis by PCR, etc. So now I say it's a clinical diagnosis, but it's very non-specific, to be honest with you. In someone with encephalitis. It's the same with VZ, it's the same with EBV, CMV, that can cause encephalitis. And in these patients, you're going to be basically giving them IV acyclovir, and it's very, very important to just cover for encephalitis in anyone who presents with these sort of meningeal kind of symptoms, because it's got a high mortality if you just give them antibiotics and miss sort of covering for viruses. So that's a real take-home point. If someone's come in and you think they've got a meningitis picture, until you get a result, then just cover them for viruses as well. All right, and obviously know about genital herpes and labial of the lip herpes as well. Cool. CMV, obviously, again, can cause encephalitis. You always cover for that. It's very, very non-specific, actually, and it's literally most of us will test positive for CMV at some point. Now, it's asymptomatic, and it's similar in its presentation to EBV, just lethargy, just feeling unwell. Now, the main take-home point that I want you to remember for CMV is anyone who is immunosuppressed, anyone who's having a transplant, anyone who's HIV positive, anyone who's leukemic, active cancer, if you're giving them anything like a blood transfusion, you want to be sort of irradiated blood, all right? So you want to be CMV negative, because it's an opportunistic infection, all right, in your immunosuppressed population, okay? You can diagnose it by PCR or IgM, but again, it's a very asymptomatic, a very non-specific presentation, but very important to remember in anyone who presents with a meningeal picture that it could cause encephalitis, all right? The other one is obviously EBV. and that targets your B lymphocytes, okay, and it just stays dormant in most of us. And the key thing here is, again, it's non-specific. You just come in a bit sort of just feeling run down and not very energetic. And obviously you get a sore throat. Lymphadenopathy is a big thing, of course, and they usually all just resolve within a couple of weeks. The real test that everyone does here is basically a monospot test. People who present to acutely to ED or to the GP, they're not going to get the results, at least for a few days. Okay. So someone come in with EBV, obviously have a bit of a swollen neck, a bit of a swollen gland around the bottom line of the jaw there, and it will resolve within a couple of weeks. Now, I saw a table actually in the Oxford Handbook, which I thought was pretty cool for anybody out there who just wants to a bit of extra reading, or if they're interested in oncology. These viruses can sometimes be quite oncogenic in itself, right? Great. RSV, let's just move on to that. I don't think we needed a question for this. Just think babies, carousal symptoms, bronchiolitis. That's really all you need to know. It stands for respiratory syncytial virus, bronchiolitis, RSV. And if you're thinking bronchiolitis, it's going to be a baby, someone under the age of 4, but more likely to be like 6 months to a year. Snotty, runny nose, difficulty breathing. That's going to be almost always your diagnosis. HPV, it's usually more studied in your either oncology lectures or your obs and gynae lectures, but it's one that I thought was worth throwing up, particularly remembering the types 16 and 18. That's the one that always comes up, because that's the one more associated with cervical cancer. And obviously in the UK, we vaccinate from the age of 12, 13. I think you can get the vaccination up until you are 30. So in case you missed the vaccination program at school, and it basically vaccinates you against type 16 and 18, and obviously 6 and 11, which is there for warts. But 16 and 18, cervical cancer, HPV, that's the one you want to remember, okay? Okay. Measles. So now we go into the childhood type of viruses, and we haven't got much longer to go here. So if you just bear with us for another 5 minutes or so, and then we'll be done. Measles. Okay, typical childhood infection, which we don't see a lot because of childhood vaccination programs, but like anywhere, you always have someone who probably missed the vaccination program, or whose parents didn't actually get them vaccinated for one reason or another. Koplik spots. You get these spots within the mouth. Just type it in Google, you'll see it. And they present just sort of like this sort of generalized rash over the body, mainly on the trunk, and just feeling generally unwell. All right. So you get a child that comes in, got some spots in the buccal region and within the mouth, with a rash. Then obviously think, this could be measles. All right. Obviously, if they've got swollen tonsils, then they've probably got and a strawberry tongue, then they've probably got scarlet fever, because that can also present a rash with a swollen lymphadenopathy, but that's obviously bacterial. All right, but it's just to bear in mind. Cool. Mums. All right, so you get these swollen glands, so swollen parotid glands in children, and again, just spread by respiratory droplets. It's basically it doesn't present very severely usually in the early stages. It's just non-specific, general sort of unwell, fever, headache. Children are not very well at describing these features, by the way. I know because I've had to cover PZD at times. So you just got to say kids come in with fevers all the time, but then they got this slightly swollen parotid gland region. And just thinking about mums again, you know, with the vaccination program, you barely see this. I've never seen it myself. The key thing to remember here is just about the complications, and particularly in males, it can lead to sort of sub fertility. Absolute infertility is very rare with it, but it can sort of reduce levels of fertility in about 10%, and it can cause what's called epididymitis, which is basically like an infection around the epididymal region and the testes, right? And it's a clinical diagnosis. And you basically, there's usually no treatment apart from just being supported, making sure they're eating and drinking, managing their fevers, managing their pain. And if you want it diagnosed, you can go for a PCR, something like that. All right. Rubella, you get the picture here. Measles, mumps, rubella, again, respiratory spread, usually very mild, subclinical. That's what subclinical means. It's not usually very severe, sometimes very difficult to pick up. Again, non-specific fever, generalized sort of macular papular rash, some lymphadenopathy. All right, so you've got to keep your sort of differentials going. Yeah, could this be measles? Could this be like a tonsillitis, which would then push me towards a bacterial picture? And if they've got a rash, could this be scarlet fever because of the tonsillitis? Or, you know, could this be sort of rubella? Again, because of vaccinations, you've probably never seen them. Like, I've never seen this, to be fair, but it's something you got to be aware of. And the key thing to remember is that in pregnancy, it's obviously very dangerous, and that it can cause fetal malformation. All right, and so you'll never want to vaccinate a pregnant lady with it because it's a live vaccine. But pre-pregnancy, it's very important to make sure that they've got up-to-date sort of MMR or even rubella tests going. I think that's part of the antenatal screen. I'm not sure if anyone's been pregnant before. You can correct me if I'm wrong there. Okay, let's go into this question. And I think we're almost at the end. We've just got a couple more to go. That should say most, by the way.
Okay, we've got the majority going for A this round.
Okay, great. So this is a lecture on virology, but I thought just to keep people awake and just to go for something different, since we've spoken about encephalitis. So if you went for A or B, it wouldn't be a problem. The most common form of bacterial meningitis is meningococcal or pneumococcal infections. Sometimes it can be quite confusing. I realised this when I think I did a lecture on this last year, where individuals were asking what's the difference between meningococcal and Neisseria meningitidis, and it's exactly the same. thing. They're just interchangeable terms. So if it's a pneumococcal infection, it's basically caused, so basically people saying streptococcus pneumonia. If it's a meningococcal infection, it's basically saying it's caused by Neisseria meningitidis. Okay. Now, obviously, typically, you've probably gone over this before in your first lecture. Meningitis, bacterial. So neonates, group B strep, okay, adults and children, meningococcal, pneumococcal. It's basically just learning that. But the key thing, obviously, for our lectures, we go over the virology, is HSV, which we've covered, VZ, enteroviruses, CMV, EBVs, that basically they can cause these sort of mild meningitis picture. Encephalitis can be quite an important one to make sure you don't sort of miss. Honestly, if you ever get someone that presents with a meningitis picture, and you're in ED or seeing them in the community, just cover them for everything until you get a result. Yeah. So you go on for your broad spectrum antibiotics, usually a cephalosporin, such as I think like cefalexin or something like that. Usually a cephalosporin, so broad spectrum, and then you go for IV antiviral cover, and I think according to microguide, obviously dexamethasone or something as well. All right, great. But you can literally just learn this. Question 8. This is just A or B. So you select one of them.
Yeah, majority have gone for B.
Gone for B. Excellent. Great. I remember getting a question like this in one of my papers at St George's, actually. And the easiest way to start off, I think, if you ever do get a table, obviously you can look at the appearance. If it's turbid, it's likely to be bacterial, but also the fact that it's lymphocytic, yeah, and the protein count is low. All right. Those are two things that helped me to differentiate. Now, you can then use the glucose. So obviously, if the protein count is high, there's obviously some bacteria in there which has a higher sort of protein content, all right? And the glucose has gone down. Bacteria, they need a lot to survive, so they're feeding on that glucose, which is why it's gone down. And obviously the white cell and turbidity will go up, so that will be B. All right, great. If there's any questions on question 8 in this table, do pop it in the chat or do just butt in. We're now on the last slide, and I don't think there's any there's not going to be any questions for this. It's just one to go over for fungal infections, and it's just one just to note, all right? Just to have this in your arsenal, or at least in your mind. So fungal infections, I would divide them in two, okay? So divide them in two. The first one being cutaneous fungal infections, and the second one being sort of systemic invasive fungal infections. So superficial, we call this cutaneous mycoses or invasive mycoses. Now, superficial fungal infections, the most common ones that you'll come across is basically your typical sort of Candida albicans, all right? And they usually infect like your sort of regions of the mouth, the vagina, the gastrointestinal tract. All right, these are normal sort of commensal areas. So superficial candidiasis. Risk factors for these, usually you'll see patients, you put them on antibiotics, and then like after 7 days or so, they've started to complain about difficulty swallowing or painful swallowing, and you look in their mouth and they stick their tongue out and it's really white, and they got some oral threat, or they got a bit of discomfort down below, with some discharges, and it's usually some vaginal thrush, or they've got a bit of diarrhea or something like that, and it's usually because the bacteria is just wiped out, or the antibiotics wiped out all the bacteria, leaving space for the candida to just go wild and just cause some kind of thrush. And then other individuals, are those who are immunosuppressed. So individuals with HIV, other immunosuppression drugs, etc., they're more at risk of getting these sort of oral thrush, vaginal thrush, these sort of superficial cutaneous mycoses. All right, usually Candida albicans. Just put that as your first thought. Now, systemically, and this is where I think on the first section, think mainly about antibiotics, think mainly about sort of mild vaginal. On the second, invasive, just think immunocompromised. Okay, yes, you get individuals who have high comorbidity, and then think about people in ITU. All right, so ITU settings and the immunocompromised, you're more at risk of getting these invasive infections. And that is a number of things that can happen here. But invasive candida is a big thing, and you have lots of other invasive fungal infections. Other one being cryptococcus. So when it comes to cryptococcus, think HIV. All right. So if you've got an invasive candida, think someone may be immunocompromised or ITU. Okay, they're going to be sort of feverish with no sort of markers of any sort of bacteria. And if it's like cryptococcal, sometimes you see it come up as cryptococcal, then think this person's probably like HIV, yeah, or some other immunocompromised state. And cryptococcal diagnosis is usually the same on the exam, the India ink stain positive, all right? If it says India ink stain positive, think cryptococcal, HIV, and that's what I'm going for. And that's basically it for today. So what we've done is we've gone over some of the most common viruses that you'll come across in practice and on your exams, and we've also touched on obviously funguses, just divided them into your superficial and your invasive, and that's it. Thank you so much. I think there's a feedback form for scanning this QR code. Any questions at all?